insurance schemes, and finally the new avatar. These are which are government or public or tax funded insurance schemes. And as we know, Dr. Ambedkar was when he was the labor minister and law minister. He actually started the ESIC in the year 1948, which is one of the first social health insurance schemes, and not only in India, probably across developing world. So one of the longest surviving one as well. And then up to mid 1980s, we had ESIC and CGHS as two social health protection schemes. But then, along with the publicly funded, publicly provided healthcare system and scattered private sector. By the 1970s and 80s, as we have studied in from the work of Professor Rama Baru and many others, who, this was the time where the private sector started consolidating, in particularly in metropolitan cities, in bigger towns, largely using the surplus from Green Revolution and other uh, surpluses from other industries. And by 1980s, mid 1980s, we see that insurance schemes are being, health insurance is being allowed. And initially, it comes through a public insurance program, which is called Mediclaim, 1986. And then by late 1990s, insurance is privatized, and that opens up possibilities of various private voluntary health insurance schemes being now, these schemes are like we know where we have to pay premium to be in part of these schemes, the private health, voluntary health insurance schemes. In the year 2003, we see for the first time in Karnataka a scheme called Yashaswini, where farmers cooperatives are being supported by government, where their premium is being paid by the government, and uh, they are being protected by insurance schemes. So the first time we see that government is putting in tax money, money from its exchequer to set up the trajectory for a private voluntary insurance scheme. And of course, before that, there were community based insurance schemes in various parts of the country, but many of them didn't survive well without public protection. Then in 2007, we see the Rajiv Aragyasri scheme in Andhra Pradesh. Late Chief Minister of Andhra Pradesh, Rajashekar Reddy, introduces that scheme. And we see that the scheme becomes very popular in Andhra Pradesh, which helps Mr. Rajashekar Reddy come back to power. And there is a lot of currency for this kind of intervention. And inspired by the success of the Rajiv Aragyasri scheme in 2008, the Labour Ministry at the union level introduces the Rashtriya Swasth Bima Yojana. So, and this is for the first time a national scheme where private insurance is being used largely, but government is subsidizing the premium, paying the premium. Initially, the coverage, as we all know, was around 30,000 rupees and largely covering secondary hospitalization. Many states by the time, and starting from Andhra and then Tamil Nadu, started their own insurance schemes. And we see in Kerala, RSBY is being topped up with introduction or inclusion of non-poor. And most of these schemes, Rajiv Aragyasri, didn't actually include only people below poverty line, but many more. But RSBY focused mainly on the poor. And then by 2018, in 10 years of RSBI, we see many states joining the bandwagon. There are more than 20 such schemes where government is paying the premium for people, largely covering the poor, but in couple of states, non-poor are also getting covered. And then we see in 2018 the introduction of the Prime Minister's Jan Arogya Yojana. Now, the features of PMJY are not very different from what used to be covered under various schemes. But for one of the main element that is being touted as one of the biggest things in all of this is the coverage up to 5 lakh, and increasing it from 30,000 to 5 lakh was seen as a major expansion. But then essential features remain the same. Mainly, private sector hospitals were implemented or utilized under the scheme, and largely high secondary or tertiary hospitalization care. In most states, as we know in PMJ, they were managed through insurance agencies, but then gradually we see governments forming their own trusts while it became difficult to manage budgets. And then it's a combination of insurance and trust models in many sectors. And then the participation largely remains voluntary for the marginalized and poor sections, but for many states for this section there is no payment. In some states, as we know, there are additional contributions that non-poor can make and join the scheme. With this background, let us get into some of the questions or major claims that government, uh, the Indian government is making vis-a-vis the PMJ and Ayushman Bharat. And there are, in the last 2, 3 years or so, we have seen many, particularly since COVID, we have seen many news reports that per capita out-of-pocket health expenditure in India is declining. Out of pocket is, when we say out of pocket, we mean direct out of pocket expenditure. When people have to pay from their own means to put their health bill, largely hospitalization. But as we know, bigger part of the out of pocket expenditure is not on hospitalization, but other outpatient care, diagnostics, and other things. But then there is this huge this thing that out-of-pocket expenditure is declining, and it is being attributed to this expansion of the government-funded insurance schemes like PMC. Now, let us look at this with a bit of data. Now, across the world, if you look at the numbers, you will see, and in here we am comparing 4 countries from Asia, where we see that out-of-pocket expenditure as a percentage of GDP is going down in many contexts, but in Malaysia, both Thailand, China, and India, out-of-pocket is declining. And if we look at global average, and if you look at these box plots, and if you see the line in the middle, which shows the median out-of-pocket expenditure per capita across the world between 2000 and 2019 in high-income countries, middle-income countries, and low-income countries, we see out-of-pocket is declining. The bar median line is declining for all the contexts. And of course, for low and low middle income countries, the share of out of pocket is higher compared to those who are the rich. But then, in many part of the world, and in these 4 countries I have compared India with, total health expenditure, which is called current health spending, which includes both out-of-pocket expenditure, but largely government spending as well. It's together, we see in high-income, upper middle-income countries, LMICs, everywhere, the current health spending is increasing. So now, but then India remains an exception there as well. You'll see that the current government expenditure, current health expenditure as a percentage of GDP is declining in India, which is very different from rest of the world. If you look at the same data, the box plot, you will see that median line is shifting upward as we move from 2000 to 2019. So this remains India remains one of the outliers. Other point, and which is major point I'm going to make here, is that unlike countries like Thailand, China, Malaysia, where public spending is growing rapidly, in India we see a very sluggish growth. There's somebody who is making marks on the screen, so it will. I hope everything is fine. Now, and then if we come the scatter plot on the right side, it shows countries or across various regions and out of pocket expenditure as a share of GDP and or as a share of total health spending. And on the x axis, we have government health expenditure as a percentage of GDP. You'll see that countries with higher public spending also brings down out-of-pocket expenditure effectively. And if we see this in the low middle income countries, we see a very strong correlation. So public spending increase brings down out-of-pocket expenditure. But in India, without any strong increase in public spending, we see out-of-pocket decline. This is a very strange phenomenon. How do we explain this decline in out of pocket and low public spending? To argue this and explain this, I'm using the NSSO 75th round and comparing with the NSSO 2014 round. Many of the figures that I have shown based on National Health Account estimates and the NHA estimates, National Health Account estimates, use the 75th round of NSSO. Let us look at the two figures we have. The bottom left one shows hospitalization rate. In the sense, per 1,000 people, how many sought hospitalization care in the year before the survey, the last 365 days. And you'll see that across rural and urban India, between 2014 and 17, hospitalization rate has declined. And this is for the first time in many decades in 1995-96 that we see a decline in hospitalization rate. The other point that I want to bring in, which is on the right side of the right side graph, is the utilization of public hospitals for various types of services. And here I compare 2004, 2014, and 17. If 100 people sought hospitalization, how many went to public sector? If 100 patients sought outpatient care, how many went to private sector? And same for the childbirth and for rural and urban areas. You'll see that for hospitalization in rural areas, the public sector utilization has increased. For childbirth, the increase is very steep, and out of every 4 hospitalizations, 3 are happening in public sector in rural areas. For outpatient care also, the overall level is low, there is concrete increase. So on one hand, there is a decline in utilization of hospital care, which is a major indicator of access. If people are not seeking hospitalization care, well, they are denying. It's not the case that they are not falling ill. And then a larger proportion of people are going to public sector for hospitalization. The increase in public sector utilization doesn't compensate for the decline in overall hospitalization. So, even though these insurance schemes are promoting private sector utilization, barring urban areas, we see, in particularly in rural area, less and less people are going to private hospitals. But then overall, more worrisome trend is hospitalization rate is declining. So access is declining in some way. And this hospitalization rate decline, you will see across quintile groups, both in rural areas and in urban areas, across caste groups. If one has insurance scheme or if one doesn't have insurance scheme, it doesn't matter. They are facing decline in utilization rate. So this point is 2014 and this point below is 2017, the rings below. So you'll see most or in all cases, all kinds of situations, hospitalization rate has declined in this period. So This is a very, very strong and very concerning indicator that access to healthcare is declining. Now, to understand this problem better, we need to compare whether this is due to severe, say, this survey was also just after the lockdown, sorry, after the demonetization. And people were recovering from the shock and they might have sacrificed care. But could it be that the NSSO data has certain problems? To do that, what I have done here with my colleague Montu is to look at the hospitalization rate for Lassi, comparing the same set of population. So in Lassi, it is only 45 plus. So we have truncated NSSO data for 45 plus years. And for all causes and also for chronic ailments, we see that hospitalization rate is much higher in Lassi compared to NSS. So definitely there is a problem in NSSO in capturing hospitalization. And look at the some of the rates here. Chronic ailment hospitalization rate is 34% in NSSO, but in LASI it is 43%. So almost 9%, 9 point more per thousand. For the hypertension, NSS reports 1.7 hospitalization per thousand. Huh? But in LASI this is 4.38. Diabetes. So some of the chronic uh, ailments, non-communicable disease hospitalization, NSS is not able to capture adequately, and that, along with the shift in utilization, has shown a decline in out-of-pocket expenditure as per NSS. Now, we have tried to corroborate this with some other data. I've used the consumer pyramid household survey to track whether over time out-of-pocket expenditure between 2014 and 18, whether that has increased or declined. And this is in real terms, in the sense we have taken out the effect of inflation. And what these two lines here on the left side shows NSS rural, urban per capita hospitalization, out-of-pocket expenditure, rural per capita out-of-pocket expenditure. Same for 2018, the midpoint of the survey. And this line shows the consumer pyramid household survey numbers. So you'll see that between 2014 and 17, per capita out-of-pocket expenditure in NSSO has declined in real terms, both for rural and urban areas, whereas CPHS data shows a significant increase. So other data sources do not support this supposed decline in out-of-pocket expenditure. Recently, the consumer expenditure survey has come up, and it shows certain numbers which are very disturbing. Share of health expenditure in overall household expenditure has increased to 7% in rural area per 100, 7 per 100 rupees, which is highest in the entire time period. In urban area, it is almost touching 6%. Basically, the point is, and then hospitalization expenditure, which is supposed to be declining due to these schemes, have also increased considerably over this period for both rural and urban area. So, contrary to what NSS morbidity round is showing, all other data sources show that healthcare costs are increasing, out of pocket is increasing, their share in household is increasing. Hospitalization rate is much higher than what NSS is saying. So we are using data which cannot be corroborated with other data sources, and that's why there is the decline in output. The other point I want to bring in, whether these schemes, the insurance schemes, are able to provide free care to people or not. And then if they are paying, how much do they pay? Look at these numbers. Here, what I'm trying to show is the distribution of, say, both government hospitals and private hospitals. And I have divided 100 cases by the level of expenditure. Say how many are, what percentage is paying less than 500? What percentage is paying less than 1,000? What percentage is paying more than 5,000 and more than 10,000? And this, the black one is the private sector, the darker one, and the gray one is the public sector. You will see that in public sector, if one goes with the insurance scheme, more than 80% people end up paying less than 5,000 rupees. More than two-thirds pay less than 2,000 rupees. Whereas if you go to private hospitals, 60%, 62%, almost two-thirds are paying more than 10,000. So more than 60%. So essentially, private sector hospitalization is, even with this insurance scheme, is leading to a lot of out-of-pocket expenditure. And that could be the reason why people are not going to private sector, even if they have the scheme. The same I have tried to now show how much is the cost per hospitalization. In the sense, out-of-pocket expenditure per hospitalization if one has government funded insurance or if one doesn't have insurance. You'll see that in private sector, both in rural and urban areas with government funded insurance schemes, costs have increased. So per hospitalization episode, the amount of money people are paying has increased between 2014 and 17. It's only in the public hospital that this remains quite low. And in public hospital, both covered and non-covered are almost equally. And so essentially, despite some of the tall claims, these schemes have not been very effective in bringing out-of-pocket expenditure down. Uh, Dr. Jagdishan, how much time do I have?
You may go up to 8:30, 8:15 or 8:30 even, no problem.
Yeah, so I have a few more slides and I'd like to explain. Yeah. Right. Now, other problems. So basically, what I tried to show so far, and few things. One, that NSSO is not able to capture hospitalization and it is showing decline in hospitalization, and that's why out-of-pocket expenditure is being shown less. Not only hospitalization, but outpatient ailment reporting is also less in NSSO. So there is a problem with the NSSO. At the same time, we see that if people, even in the NSSO data, when people have the insurance scheme and they go to private sector, they are making ending up paying a lot of money, and which is uh, pushing them away from the private sector, and more people are utilizing public hospitals, realizing that that's where real free care is at. Now, there are many other challenges that these insurance schemes are bringing up. One of this is the issue of induced demand, that unnecessary care because you have been you have the insurance card, you are being subjected to care, surgeries, procedures, hospitalizations, which we do not actually need. You do not actually need. So, and then this becomes a source of profit for the private hospitals, but then government exchequer, there is a loss, and then for us also, we end up paying out of pocket expense. So, now, induced demand has been very difficult to capture given a lot of information. Asymmetry, medical care decisions are often left to the rightfully left to the discretion of the medical provider, which should be the case always. But then, because their interest is vested with the interest of the hospitals and the profit that hospitals are aiming to garner, we see induced demand happening, and in the sense, unnecessary care being provided. I'm trying to demonstrate that point using one particular example, which is the cesarean section example. Now, if you look at NFHS 5 and look at cesarean section rates, you will see that if you do not have any insurance scheme, your cesarean section rate is 18%. If you have government funded insurance schemes, cesarean section rate jumps to 26%. But if you go to private sector, your C-section rate is 43%. If you go to public sector, or if you have JSY, the cesarean section rate remains along the standard 10 to 13%, which is slightly on the lower side, but definitely less of induced demand. Here, the problem could be that some people who need C-section are being denied. But if you have insurance scheme and if you go to a private hospital for delivery, your cesarean section rate is 55%. More than half of the deliveries under these schemes are happening under cesarean section. The same, if you same person goes to a public hospital with the scheme, cesarean section rate remains around 17.4%. So not very different from the standard 10 to 15%. So definitely, and there is the debate around cesarean section is still open, but we can at least safely say that many of this, even in the best possible scenario, best possible intention to provide safe delivery, cesarean section rate cannot be half. It has to be much lesser than this and ideal. And this builds a strong case for induced demand. That unnecessary care is being provided under these schemes. Now, there are several other exclusions, and here I'm talking about PMJ alone because many of the scheme evaluation data are scanty. In public domain, there is no data for PMJ or many state schemes. It's only that there are a couple of RTIs which some of the journalists have brought out and the other important source is the CAG report, which brings out certain anomalies in this case. So if you look at, say, as per the RTI, and this I'm quoting Richard's piece from NewsClick, that only 4% of private hospital admissions under PMJ happen for Dalits and 1.6% for STs. As we know, the share of population of these groups are much higher. So ideally, the hospitalization rate or admission should have reflect the population share of these groups. So definitely, the most vulnerable, the marginalized communities are being left out of these schemes. And at the same time, I want to bring in that these schemes are you start pushing people towards more tertiary care. And as we know, who are the providers of this tertiary care? The bigger hospitals, the specialists, the more surgeons. And as we know, many of these overwhelming majority of the class who are benefiting from these schemes are upper caste, Hindus, and so all which where the share of who has majority of share in among the surgeons, among the medical care professionals, among the specialists. So definitely, this is a scheme where poor, marginalized are being excluded, whereas the benefactors are the upper section echelons of the society, including the owners of private hospitals, the corporates, the individual owners who are overwhelmingly. And then there are huge issues of corruption, there are duplication of beneficiaries, multiple cards being issued against same name, inappropriate procedures are being done, plenty of cases of uh, younger women being subjected to permanent sterilization methods or removal of uterus. So we have seen such cases coming up, on only few cases coming up in public. Hmm. And many of the beneficiaries who are having the card are often being denied. I can give an anecdotal evidence here. I was in a exploratory visit to tea gardens in North Bengal, and many of the group discussions that I was part of, the garden workers said they are denied care under PMJ, even if the hospitals are empaneled because they do not have adequate political clout. Sorry, not PMJs, the West Bengal Schemes Society. And I'm sure there are many such examples around the country. Now, but then in contrast, what is happening is there is huge expenditure being made on these schemes. And this is from National Health Account Number. And if you look at, compare the period of 2013 to 2019-20, for which we have NHA data, we see that PMJ expenditures are more than doubled, around 4,400 to almost 10, more than 10,000 in the span of 2019. There is an interesting issue here. Though this is all government funded health insurance together, you see that PMJ, which is the union government scheme, the utilization of expenditure remains very low. Whereas for rest of the schemes, there is a huge increase in expenditure. What is the problem? What is the issue here? If you, and here also I am quoting some state government anecdotal reports or some initial observations coming up from newspaper, is that many of the states are topping up PMJ with their state schemes. For instance, in Haryana, there is a scheme called Chirayu. And in these schemes, essentially non-poor are being included, often with a small payment, but many states that also is free. And when non-poor are being included, utilization under these schemes increase very much, and that shoots up the budget, eats up the allocation that is there, largely made by the states. So while for the poor and the needy, uh, there is low utilization, they are not able to seek care. The non-poor are benefiting from the schemes, and the money is largely coming from the state exchequer. Now, in contrast to huge increase in spending on these insurance schemes, if you look at, say, union government and state governments, their spending on health, you will see that the top right graph shows the union government spending on health as a percentage of GDP, which is at the bottom, and at the top is the state government spending. You'll see that union government spending, barring the COVID years and after COVID years, also has declined very sharply. It was only during COVID that they could spend a bit more, but then they have quickly corrected their mistake and brought down public spending on health significantly. Whereas states have significantly increased their public spending and they have sustained that in the post-COVID period. There are, there are chats. So, okay. Sorry, is there any question? Ravi, thanks for your comment, Ravi. Yes. Yes, right.
Indranil, you can answer it later after the presentation, otherwise it will get interrupted.
Yeah, and others can read, and Ravi is essentially complementing with his remark. Thanks, Ravi, for that. Right. But if you compare this, so what is the point? Basically, union government is bringing down public spending post-COVID, but state governments are sustaining, they are putting in more money on health. So whatever increase in spending is essentially by the state government, which is a very positive trend and which needs to be sustained. But it cannot be that while states are taking increasing burden of health, union government does away with itself. In fact, union government is cutting down its spending on NHM. Look at the NHM numbers in real prices, 2013-14 prices. So in 2017-18, the Union government was spending 25,000 crores in NHM, and these are in 2013-14 prices. So these are not actual allocation, but we have taken out the effect of inflation. But then, if we compare this now in the 2013-14, this comes down to 20,000 crores. So whatever service Union government could provide through NHM in the year 2017-18 cannot be provided now. Population has expanded, NHMTT has expanded to non-communicable diseases, climate change has been included, many vertical disease control programs are part of NHM now. National Urban Health Mission is being expanded, but you see that the NHM spending by state union government is being cut back significantly. So, and if we compare public spending on health in India with other countries, and here I've kept the BRICS countries along with India. We have Brazil, South Africa, China. I've taken out Russia because it's hardly comparable with India. And if you compare India with our neighboring countries, even say Bhutan, Vietnam, Sri Lanka, Indonesia, you'll see that in per capita terms, like say China spends 15 times more, Thailand spends 10 times more compared to India. Even Sri Lanka spends 3 times more compared to India. So we definitely need to augment our public spending, and large part of it should go to strengthening public system because that's what the one which is delivering. Now you can say that, see, we are a low middle income country, we may not be able to afford. So for that, I have brought in the graph in here. These are countries. Here I have taken on the x-axis are the per capita GDP of a country, and on the y-axis we have per capita government expenditure on health. Essentially, countries who are around the same level of per capita income. And you will see that India's per capita health spending is among the lowest. Even countries which have lower per capita GDP are spending much, much more compared to India. In fact, the second lowest in this group. So, there is a need, there is a strong evidence that our per capita, our government health expenditure need to increase, and that should be diverted towards strengthening the public system. And uh, unfortunately, much of that public spending, whatever is being done, is being used to, you know, change the boards of some of the important institutions of primary care like health and wellness center to Aragya Mandir. And this is a poster we brought out as part of JSA during the election campaign. And with that, I'll stop here more for question and answers, and I'll be happy to respond.
Thank you, Indranil. Very comprehensive and insightful presentation with so much of data. So now the session is open. You may answer one or two, not exactly question. One is, of course, Ravi's comment, and second one is Rajalakshmi's this remarks. She has specifically asked about the opinion on this Tamil Nadu method of using PMJY through government hospitals and utilizing that insurance money for development of the hospital. Even Kerala also tried that and is doing that. The hospital management committee get this amount and utilize it for the hospital. So you can give your comments and.
Right. Okay. Shall I respond to?
Sure. Other clarification also you can give. We have sufficient time.
Yeah. Right. Thank you. So definitely this is a way of mobilizing resources, and I'm sure we have to really study how much resources the public hospitals are getting. But I want to highlight a particular problem. There's an incentive problem here. So, in a public hospital, many of the tasks are not incentivized. For instance, if you do a comprehensive outreach program to identify early cases, if you are treating patients at outpatient department, if you are managing cases in the emergency where there is no hospitalization required, many of these are not incentivized in terms of your performance. There is no additional payment. You get paid from the uh, mm, but then PMJ kind of schemes or insurance schemes are creating incentive for public hospitals to generate revenue utilizing or providing care of this kind. Definitely, this will create a lopsided incentive against uh, more public health interventions, more outpatient care, and they'll also push patients towards uh, costly inpatient services, surgeries, and you see induced demand taking place. So you are essentially distorting the way public sector needs to function, which is to through a public goal and looking at epidemiological consideration. So though this may look at a short as an attractive short-term strategy for a particular hospital, but I don't see this as other interventions that public sector has to do, a government hospital has to do.
So, so now this session is open. Either you can unmute and ask question, or you can hand raise.
Hello. Hello.
Jackson can hear us. We can hear you.
I want to get opinion from my Indranil. It is said it is going to be our national budget present in 23rd, coming 23rd. It is heard
Right.
that the PMJ, the coverage will increase to 5 lakhs to 10 lakhs. I want to get comment from you.
Right. Yeah, and this is becoming again a very contentious issue. Rajasthan said we'll cover 20 up to 25 lakh, and then many other states have coverage of 10 lakhs. Union government has to respond. But if you look at PMJ or any other insurance schemes or any fraction, this 10 lakh coverage is not for everyone. So, and most of the 99% or 99.99% of the procedures, the schemes will or exact packages will not need coverage beyond 1 and 2 lakh rupees. This is more of a political game. But what happens is through that, if there is a limited budget and if you pay few people 10 lakh rupees, which means that that you are substituting care for many people who could have afforded or who could have been given care at a lower rate. So most of the procedures might cost 50,000, 60,000. So one package, which is what paid 1% 10 lakh. In any case, there for extreme high level expenditures, many state governments had the chief minister's fund from where you could get a special allowance. But this is again going to create incentives for tertiary hospitals to, jack up the procedures, show overbilling, and claim some of the money. The gain would be for a very limited number of people. There are certain questions on the chat box. Shall I take?
Sure, sure.
So the thing is, whether IP care utilization has come down or not, though NSS shows a decline, I tend to challenge that. Really show that hospitalization has declined. So that is the point. Of course, outpatient utilization need to also increase, but then NSSO shows a decline in outpatient utilization as well. So yeah, point is NSSO may not be used for all of this. There needs to be other adjustments. Okay. Now there is a question here that there is a significant challenge of India's low spending on healthcare in compared to other countries. Is there a significant challenge? Is there a significant challenge? Now, as I said, state governments are overcoming their challenge. State governments are realizing that health is an important subject and we need to mobilize more resources. It's the time for union government to step up and spend more. Health. So there was an attempt to make health a concurrent list subject, but it needs to be recognized that this is a state subject, and union government need to hand over greater share of their finance commission resources to state so that this effort by states to increase spending can be substantiated. Union government also need to step up its act. But I don't see a major challenge if there is no challenge on part of the exchequer. If government funds, they can increase public spending. Resource mobilization is not that difficult. India and instant is not going to increase the proportion for political bosses should sensitize the importance of public spending, private sector. I'm not responding. Public spending going down as percentage of GDP, any specific area budget item where this cut down has been made in the last 3-4 years. NHM, which is the most important scheme, which has saved thousands and lakhs of lives of mother and children, which has strengthened the rural primary secondary care in large part of the country, is now being denied budget. And this is the time where NCD care needs to be expanded to NHM. The NCD care package remains very limited. There is very little expansion, underutilization of funds. How do we put pressure on the NHA to look at independent, reliable evidence on impact of the scheme, as they don't see to be acknowledging the gaps, neither are they sharing PMJ data, RTIs are rejected. And I know Rajlakshmi knows the answer. To us, it is not accountable to any government institution. It's an autonomous entity. It has come through so even Parliament cannot hold NHA accountable. It's highly problematic. It is taking decisions on public spending, on union government spending, on major schemes, and we need to bring it back to accountability, and that should be a major advocacy point for us. Thanks for pointing out. There is no need to worry about spending now. Corruption in public institutions should be looked into. I don't tend to agree with that. There are certain states where public spending is increasing, but then in many states, the basic primary care infrastructure is not put in place. The health and wellness centers are not functioning properly. Most of the primary health centers do not have skilled human resources. There are huge vacancies of 85% vacancy of specialists at CHC level. We need to fill this out, and without increasing public spending, we cannot do it. That doesn't mean we don't have better accountability and low corruption. But then there are certain things which you can do with less money, but there are certain things which need more money. For instance, if you improve the procurement system of medicines, you can bring down out-of-pocket expenditure. That may not need a lot of money, but a reorganization of the procurement system. But what about filling human resource gap? What about providing diagnostic services that needs more resources? What about, say, even if you want to monitor, if you want to improve the surveillance system, if you want to create a cadre of multi-purpose public health worker on ground in local bodies, you need more resources. And local bodies need to be strengthened.
Indranil, there
Can
is
you
a new question. Can you suggest any alternate health financing for India?
So, alternate. So, the alternative is the traditional way. Instead of, see, there are advantages of government funded, publicly provided services. You can really orient that service towards epidemiological goals, towards public health goals. You can really plan your services well. You can bring down the cost by economizing the scale. You can improve efficiency of all of that. But that needs greater accountability towards people. That those accountability mechanisms are required. Public participation in the decision-making process are required, not the way currently done, but that is the most sustainable way. You look at countries which have provided better care at lower cost, all of them have a robust publicly provided system. Even Thailand, which on paper says that it will compensate the private sector, the thing is, Thailand public system is so strong that it has outcompeted the private sector. In Tamil Nadu, we see that happening to some extent. In Kerala, we see that happening to some extent because their public system is very strong. But the rest of the country, the private sector benefits extensively from these kind of schemes, and we need to challenge it. We need to bring public systems on board. What is needed? What if you really want a reform? It One of the things we need is greater devolution of funds to states, but much more towards local bodies. Much of the climate action, climate and health action, the public health preventive action, the primary care action has to happen with the help of local bodies. And we need to strengthen that. Out of 100 rupees spent by government on health, only 2.7 is spent by local bodies. Local bodies do not have their own resources, and very little money is being given to them. Kerala remains an exception, but we need to bring back people's plan uh, in rest of the country, or strengthen it in Kerala. But for rest of the country, we need bottom-up planning where local bodies can be involved in care, in health, in public health, in accountability mechanisms.
Indranil, we used to have more and more questions generally, maybe because of the technical nature of the health financing topic that questions are less. So let me just ask you, not in terms of as a public financing expert, or I am not, which I am not. What is the way out? We know that there are issues from the very beginning, beginning in the sense empanelment stage of a insurance scheme till ensuring the payment, whether it is to the government or to the private hospital. Only after getting the payment, private sector and all, they would release the patient or even dead body for that matter. So what is the way out? We cannot, at this point of time, we cannot just run away from health insurance schemes, especially state governments cannot take such a decision. And moreover, because of the people's demand for Kerala and all, comprehensive health insurance, additional state fund is also being incorporated, and more sections are being added to that. How exactly some form of a democratization of this publicly funded health insurance scheme possible? I don't know, since you are part of EMFC and part of this JSA and all, how can we proceed to just to think of a village where how many are denied the empanelment, or how many are denied the treatment, how many are how many was treated irrationally, or that way? How can we pursue this further and to make some inroads into, or some intervention model into the this health insurance issue? And of course, it is related to the privatization trend also. This also somebody commented, Ravi rightly commented, that the privatization and corporatization was going side by side with this increase in insurance funding. So what is the way out? And so I think I made my point clear.
Right, absolutely, and a very, very important observation and comment, and in terms of another question also, it is important for us to find a political way also. And given that these schemes remain popular, and once the state has committed to it, it's very difficult to roll back. So what do we do? Now, we need to probably follow the Thailand route, which is two things. Two, like two broad pathways, and there are certain details. On one hand, we need to strengthen the public system, because public system has competitive advantage. It can drive down the cost and also provide better quality care. Second point is that create disincentives for unnecessary care or demand inducement. For instance, I'll give a simple example, and this is being experimented in many states also. Say if you have higher payment for cesarean section. Say if under these schemes, if you go through cesarean section, you get 25,000. But say if somebody does normal delivery, you are paid 5,000. Now, obviously, this will create incentive for cesarean section to happen. But if you change the incentive and make it in a way that for every delivery, the hospital will get paid, say, 8,000, irrespective of whichever way you deliver. That will immediately bring down the cesarean section rate, because hospitals gain from normal deliveries, because they are gaining 3,000 rupees every normal delivery. So that way you can bring down this induced demand component. There are certain procedures where it is induced demand is more possible, and there are very little checks and balances, and there are data. There are many states that doing this. Certain procedures are getting reserved for the public sector hospitals only. If you have to do a vasectomy, it has to be a public hospital. If it's a cataract surgery, it has to be public hospital. Knee replacement surgeries are becoming very popular under these schemes. Huge induced demand. So you need to think of reserving some of this. That's one. Other important thing that needs to be done is that every procedure that is done in the private sector needs to be referred by a public institution, with the clause that public, it is not available in the nearby areas within the district or within a defined geography within the public system, or there is a huge queue in the public system. That's why, so basically rationalize the utilization of private sector on very strict principles of complementarity. That this is not available, say emergency procedure needed, public sector doesn't have beds or OTs available right now, or there are challenges, you can refer. But every utilization of private has to be referred. Some argue that this is a contentious issue. Many people might be denied care. Then there are corruption issues that creep in. But some of these practices are being done and have been done very effectively. Karnataka is experimenting on those lines. So basic point is so create checks and balances and disincentives for overutilization of private sector, and make the public sector the central point of delivery and public care. The other point, which is very crucial, and you hinted upon, how do you democratize these schemes? If you look at the grievance redressal system, they remain so away from people. You can only register your grievance to the same hospital where the so basically you are making the police, the criminal, the police, and also the judge the same hospital. If they do not forward your grievance, then you are not your grievance is not heard. We need to create greater accountability. Grievance redressal mechanisms are way to create greater accountability, and we need to put more pressure on these. So even if we are not able to do away with these schemes in a day or in a span of year, over time, with strengthened public system, with greater rationalization of care, there is enormous pressure from the private sector to increase the package rates. That needs to be resisted also. And if the government is providing more care, then automatically there will be cost saving on the part of the government, even under these schemes. Yes, and very good observation by Jai Krishnan that all insurance schemes OP care is out of coverage, which constitutes more than 60% of the out-of-pocket expenditure. Definitely. And large part of the chronic care, even NSS, doesn't capture the routine chronic expenditure, which is a huge. Look at any family that has an elderly person, one or two, would know how much the medicine budget has increased over last 5-7 years. My parents' medicine budget has increased more than twice in the last 5 years, and that would be the case for many people like us. Dr. Vasudevan, sorry, you are on mute.
Vasudevan, please unmute and speak.
Is he not able to unmute?
Yes. Now it is okay.
All right.
It's okay. Almost all insurance schemes are total failure. That is why most of the opinions from different parts of the world, and also I am from Kerala and I have got the experience of the same thing. What is your opinion?
Like, I was probably trying to argue the same with a lot of data and a lot of jargon and terms and arguments, but yeah, the basic point is the same. I agree with you. The only thing is, we may not, like Dr. Jagdishan suggested, we may not be able to undo this. Somebody has started a whiteboard.
Narendra Kumar, your whiteboard is on. Please remove it.
Is he the host?
Suresh, somebody's whiteboard has appeared in the screen, on the screen. And I think we can hear you. Vasudevan, you can continue, and Indranil, you can reply.
Yes, the thing is that actually almost all schemes are insurance schemes are total failures, because there are a lot of points there. Because the insurance schemes, most of the hospitals, they are not empaneled in that, because they are not interested, because they are getting, it's a very just like a package for, suppose for delivery, for doing a hernia, suppose surgeries like that, it's a package for and also there is a cut on spending daily. So suppose you are in a ICU, you will get only 1,500. Suppose you are in a ward, you will get only 750 rupees. And yeah, that is not possible for hospital to treat the patient. So most of the hospitals, they are not interested in joining the scheme. And that is why it is a failure. Even the scheme introduced by the government of Kerala for the employees and for pensioners, that also is a failure. The government is also trying to stop it now. And some hospitals, they are not doing knee replacement surgery, or you have to waiting for period is there. And some hospitals, they take only some cases. For example, for angioplasty, some hospitals are taking angioplasty only. Other general medical case, they are not taking. They are not taking some surgery case also. These types of things are there. So in order to overcome this, I recommend that universal healthcare coverage is what we have to recommend, because the government of spending only 1.2% of the GDP. And as you said, the central government, union government is spending only 0.2%, and state government is also spending around about less than 1%. So the GDP, you have to spend around about 5% of the GDP for the healthcare. And in certain European countries, they are spending around about 15% of GDP for healthcare. So that type of approach and is necessary for implementing universal healthcare. That is my opinion.
Indranil, also I think the regulation, registration and accreditation of private hospitals, that should go parallelly if private hospitals are permitted to empanel for the insurance. And but
So,
this regulation and
definitely.
registration, accreditation things are in a very bad stage in the country, though a bill was passed at the national level. And few state government, they also put forward their bills, but at the implementation level, it is in a very bad stage, and that is another aspect of the another side of the issue, I think.
There are many aspects to that, and I completely agree with you that the hospitals need to be regulated strongly, particularly private hospital, both public and private, and of course the terms of reference for regulation is very different for public hospitals from that of the private hospital. And in the public hospital, private hospital, there has to be rate regulation as well. Like you can't charge 50,000 rupees per person per day on beds, which were some of the charges during COVID time, and Supreme Court had to intervene. And so, complete absence of regulation is a major challenge. What are the elements of regulation? Of course, rate regulation, standard of care regulation on standard, and that needs to be like we can't expect a small nursing home to have a standard which is akin to a corporate hospital. We are not saying that. That can be also varied, but there has to be certain benchmarks, certain gradation of standards. There is no deny. Give regulation of standards. Certain basic compliances are not there. Even if in cases of national emergencies and epidemics, there is inadequate reporting. If a private hospital is getting public money to treat patients and they're making like the huge profit of public money, why are not they accountable to give the data to government? Why are they not sharing the data? The basic things are missing. And this is very unique to our subcontinent and some part of East Asia also. China also hardly has any regulation. But the point is that without regulation, much of this cannot be done. But then, can we really regulate the private sector? Any effort towards regulating private sector, any right-based progressive legislation, how vehemently the big corporate hospitals, the IMAs, which constitute mostly secondary hospitals, and the surgeons, the super specialist doctors. This lobby is so strong that any progressive legislation will be vehemently opposed. And that's why the Clinical Establishment Act has been rather weakened, not being implemented by states because of the a strong lobby by the IMA, and that needs to be like if you don't counter some of the strongest political forces in the country, you will not be able to make progressive change with the public system, with public health in the country. So that needs to be taken, confronted, the lobby. And it's again the consolidation of upper caste, upper class, urban elites, who constitute major force of a section of the super specialty doctors, the surgeons, the owners of private hospitals, the nursing homes, and their stronghold within the state and within the health system is a major deterrent to any progressive legislation, and that is one of the challenge why public spending doesn't increase on health. But there is a strong resistance. We saw what happened in Rajasthan, but I'm not saying it. There are states who are trying to do certain progressive things, and we need to strengthen those.
Rajalakshmi, you put up a very significant comment regarding Kerala and Tamil Nadu. Why not to and the civil society to come forward? Why don't you unmute and speak about?
Yes.
You also earlier also you put up some very meaningful comments and.
Yeah, thank you. So basically, I feel like it's very difficult to reverse the introduction of the health insurance scheme. Seems to have a lot of support for the political economic angle. But at the same time, what we can do is engaging in this issue. A lot of people do not understand what it means when out-of-pocket expenditure has increased or decreased. How is it related to total health expenditure? So I think as activists, civil societies, NGOs, we need to understand this complex insurance mechanism itself and engage and keep raising the issues. Somebody had asked in the chat also, what are the research priorities that could be there? Although even the existing research is actually falling on years that it's not even falling in the ears of the concerned people, but still we can keep putting pressure by creating generating evidence on its effects. For example, what is actually, how is the government hospitals really benefiting from this insurance scheme? Are they discriminating between the poor patients, etc., and how are they utilizing the revenue so-called generated? And keep checking checks and balances and keep putting pressure on speaking from the point of view of the most marginalized people, that if we keep doing that, at least the states can respond to it. I think Kerala, Karnataka, Tamil Nadu, the states are somewhat more responsive than some of the other northern states. At least we should be able to engage with the group and ask for evaluation studies, ask for an independent committee to review the recent trends and evidence like that. Something we have to engage, because fearing the complexity, if we take a step back, then all the more then this is going to become more and more a very skewed priority in our health system.
Absolutely.
Thank
Can't
you.
agree more with
Indranil, you can respond.
So on the research question, thanks for, I missed that comment. Thanks, Rajyoshi, for bringing it back. So, there are large surveys. We may not be able to do that kind of survey easily. But what we can do, and that's where individual researchers have seen, is to bring out experiences of people, like those who have gone through, say, this kind of scheme and access service. What are the challenges they're facing? What are the kind of discrimination a poor person face? If we can, even in small scale, if we can, through qualitative studies, through case studies, through various other qualitative methods, if we can bring out experiences of people, of a particular hospital, of certain providers, probably that will also throw a lot of light on the challenges, and also we have to keep asking the government for better data, make them government accountable. And also, like Rajalakshmi has pointed out, we need to ask for independent review, and these schemes need to be reviewed independently with public money because it is our resources. We can't do as individuals all the time, but government should put in that resource.
Indranil, there are three more comments or question. One I can even this Bashir has asked the point is that the need for increasing the local government's expenditure in health and all. But in relation to that, I would like to raise one issue. Though Kerala, we are all very proud of the local government's Panchayati Raj system's role in healthcare and all. What is the Panchayati Raj institution's role, or local Panchayat, Gram Panchayat, or other Panchayat's role in ensuring effective implementation of the health insurance, publicly funded health insurance scheme? I don't think any role for them. They are not in a position to make sure that all the deserving are empaneled, or those who really deserving are getting the treatment through the scheme, or what are the reasons for rejection and how to address those. I even myself tried to raise these issues at many of the decentralized planning meetings, but that never carry forward and by the responsible persons. So other part you can respond to Bashir's question, and two more questions.
So that question should enlighten members of the medical profession and not offer our new government the benefit of their experience, whether they're asked for it. I don't have any answers, so I'm not responding. But other question by Dr. Aparna, can you throw light on the trend of public versus private sector healthcare utilization among people below poverty line? If still private utilization is more, then what might be the reasons for it despite out-of-pocket expenditure? If public care utilization has increased, what might be the attracting factors towards government sector? How can we sustain these attracting factors? Has the government spending on upgrading the infrastructure of existing hospitals helping in reducing the flow of patients towards private hospitals? Yes, right. I think there are many points, and I would wish I had shown the uh, breakup of utilization of hospitals by the poor. So, if we look at overall utilization of public sector, it is essentially by the poor and the margin. Huge portion of the public hospitals are being used by the poor and the margin. But then, if you look at the where poor are going, they're also going to private hospitals. But why are they going? That's the question. When people are asked to spend a lot of money, why are they going to private sector, even if they're poor? Two reasons. One, first of all, take one case, say the case of maternal and child health, the deliveries and early neonatal care. Huge utilization. Almost every poor person goes to public hospital. That's because that's the only kind of care that is comprehensively available within the public system. The whole focus of NHM has been why are these private insurance schemes are being brought in? There is a concrete gap that you see in the care that public sector provides, and that is the say some of the surgical procedures, say care for the non-communicable diseases, the cardiac surgeries. We need to refer back to the structural adjustment program and the selective primary level care. The kind of reforms that public sector had been subjected to in the 90s and the early 2000s to provide a narrow set of care through public system, and rest of the care would be provided by the private sector. The point is, most of the NCD care, particularly surgeries, have not been provided within the public sector in most of the states. That's why people are forced to go to private sector. That's a question of saving lives. So, but then what attracts? If you provide certain comprehensive care, if you can provide medicines, if you can provide diagnostics, if you can provide certain basic service qualities, people go to public sector, and there are plenty of examples of. Ravi mentioned some states like Sikkim and others, where there is no private sector, public sector is delivering really well. If you give the public sector that kind of opportunity, it is delivering, and that is the lesson we need to draw from NHM and strengthen the schemes like NHM. Join.
About Himachal Pradesh scheme, there is a
The
question.
same. Think so. This home care is similar to the Chirayu scheme in Haryana. It's going to create a lot of loss of exchequer if we include the non-poor into this kind of schemes. Himachal, the additional issue is there is no private sector within the state, so people go to Chandigarh. So home care. Just because private sector is not developed enough, they are able to survive, but it will come up and then it will create a huge loss. Compared to UK, in India, 60-70 health coverage is by private sector, except that with all limitations, India has a better system. 60-70, so the private sector utilization is coming down for hospital care. That's a positive thing. And for deliveries. But overall, I agree with Dr. Iqbal that a large part is particularly the outpatient care is within private sector. But that private sector is not necessarily the corporate. That's a small provider. That many states both deliveries. Yes, both deliveries and hospitals. What is that reference? Oh, that's Himachal example, right? Anything I'm missing? Any of the comments, important comments I have missed? Yes, UK reforms are very, like, I think all of us should read the Global Health Watch and various volumes of Global Health Watch, which has documented the People's Health Movement publication, which has documented the UK NHS reforms, but the kind of marketization, the internal competition that is being undertaken within NHS, and very disturbing trends, but hopefully some of it will be reversed. Dr. Jagadishan, shall we, how long shall we continue, or do you see any other burning question? Dr. Akshat has raised his hand.
And I think we have discussed quite a lot, and I think there is a general feeling among all that there should be further work upon this topic, especially public health people's or from the side of organizations like MFC or JSN. What should be the intervention like? So something like a concept note on the intervention areas on for I would say democratization of the these health insurance schemes, or making it's really available and accessible, and on a scientific basis, not the irrational moral hazard side care. And so that should be taken up, and for all those things, let this this Indranil's presentation and further discussions lead way to that. And so hopefully, since we would be comparable sessions in the coming weeks also, and also during the offline August 10th and 11th also we have session on regulation, registration, privatization issues. Everything would be coming. May not be health insurance as a topic. So maybe after the MFC Calicut meet, we should think of that type of a intervention concept paper on health insurance is needed, and
Dr.
we should try
Jagdishan,
for that.
Akshat has a comment. I think raise his hand. So shall we spare a couple of minutes and hear
Sure,
from
sure.
him?
No problem, no problem.
Yeah, thank you so much, Indranil. So I have two parts to my question. One is a kind of submission that just on the discussion that we were just having on the uh, below poverty line people going to private sector. So there is kind of, I just agree with your point, and there is kind of, if we go through the epidemiological history of their point of contact in healthcare, they usually go to the public sector hospitals, and then after 3 or 4 contacts with the public sector hospitals, whether it is the PSC, CSC or district hospital, they end up in a private hospital. So that is there. Just for my understanding, I just wanted to understand in the NSS data and all that, are the unregistered private hospitals also counted in the survey? That is the first part. And the second part is regarding recently there is some corporate hospital, I think Dr. Devi Shetty's, which started off a health insurance scheme of their own. So I just wanted to understand whether this is a trend. I understand that this is a trend that is going to be in vogue in the coming years. So how is it going to impact the single doctor or the single or the smaller nursing homes or the single doctor clinics, more so in the urban sector, in the urban areas, for people living in the urban areas? So these are the two questions. If
Right, wonderful questions. I'll just respond probably inadequately, but briefly. One thing is, say, a large part of the poor in urban areas or in rural areas go to the informal providers. NSSO is not able to capture it adequately. It doesn't categorize particularly the current last 2 rounds of NSSO has not been able to capture it adequately. And also, when you go to a informal provider, that provider shapes your care pathway. So there are only when they realize that this person cannot afford, they will send you to the public hospital. But otherwise, they will be diverted to the private sector, and that is another reason why private sector utilization among poor is increasing. Other point about the Debbie scheme, and it's very significant in the sense that this is in line with what you see in US healthcare industry today. It's like similar to the health maintenance organizations or preferred provider organizations, where particularly HMOs, where the same entity is providing insurance care services and healthcare. For the insurance company, this actually helps bringing down the cost and monopolizing profit. So it's a very disturbing trend, but it is one of the ways that I think health system is going. And remember, HMOs came after the Medicare, Medicaid was put in place in US. And Medicare is similar to, or Medicaid particularly, similar to the government-funded insurance schemes. So now we see HMO kind of institutions coming up in India. So essentially, the whole direction of our healthcare industry is towards this kind of US kind of model, and it's going to be very debilitating for a poor country, relatively less resource country like India. The other crucial point is there is a lot of structural change happening within the private sector. And this is the last point I'll make, is that, you're right in saying that the individual GPs, small nursing homes are being wiped out. In Delhi, today, you will not see us, you'll hardly find a GP. In large metropolitan cities, individual practitioners are completely being wiped out. So the same is the story with small nursing. A lot of private investment is happening in healthcare, but you will not see expansion of capacity. It's essentially taking over mergers and acquisitions by the angel investors, the institutional investors, the share. buying up share. So essentially, move towards oligopolization, corporatization of healthcare market. In US, if you look at the last 20 years data, you'll see that the hospital, like bed population ratio, has declined. Why? Because huge monopoly, oligopolies have been created. They're bringing down the number of beds so that prices and they can charge higher prices. And we see similar trend here. We need to carefully watch and yeah, I think Richa is right. We should keep up the hope that there will be good things. And all I'm saying is very like yeah, suggesting towards more worrying trends, and it is not the way to end. I'm sure there are good examples, and we have to fight and counter this dangerous tendencies of corporatization, privatization of healthcare.
Thank you very much, Indranil, and the whole team attended till 9:10. Now it's 9:10, 9:30. So we had so much of discussion, and there is in the end there is a comment from Rajalakshmi, a hopeful comment. We should carry forward these things, and so thank you everybody. And our next week session is something related to right to healthcare movement in India, and especially on legislation in Rajasthan. Abhay Shukla and Chaya from Rajasthan, both are JSA's activists, and they will be speaking on. And so let us meet again next week, same time, Thursday, 7:30. So thank you everybody, and good night.
Thank you. Thank you.
Thank you, Indranil. Thank you.